We won't be able to go a lot in depth, but we'll sort of do an umbrella. You've actually had a talk. These two were supposed to sit together about the adipocyte, and my talk was supposed to follow the adipocyte because it clicks very well together and there's a bit of overlap in the subject that we would have been covering. So, what is ectopic fat and why do we need fat? Right? We know that normal fat is subcutaneous. One of the normal fat depots, we have several normal fat depots. One is subcutaneous fat just under the skin, and this is the one that's most visible. It's more concentrated, for example, thighs, buttocks, for some people, the apple versus the pear, but this is still physiological. You need this depot, right? Then you have visceral fat. Visceral fat, as long as it is in an appropriate amount and in the right site, is still important. And it's usually surrounding the omentum, surrounding the liver, the pancreas, and the intestines. However, if the visceral fat is excess, this is where you run into metabolic problems. Now, fat's not just a storage. Remember that fat is metabolically and hormonally active, and it's a huge endocrine organ and secretes a variety of cytokines and other inflammatory pathway related molecules. You also have a little bit of fat in the muscle, and this is available for energy during exercise, but excess fat accumulation in the muscle again can be deleterious. Dr. Krishna Sheshadri briefly mentioned brown fat or brown adipose tissue. Now, more important in children because it helps maintain body temperature, but in the adults it's primarily found in those muscles that have sustained function. So, for example, your neck and spine, where you need this tone and the muscles constantly need energy, the brown fat is a source of that. And there is a whole research arm now on browning of the white fat. So these are normal fat depots, and these serve as a buffer against energy fluctuations. You eat yesterday, you don't eat today. Remember, we didn't evolve to have a fridge and access to food 24/7. We've evolved to go through periods of fasting and feasting, and your normal fat depots acted as an energy buffer and energy storation, but also, as I said, as a huge source of metabolically active secretory tissue. Some fat is essential to health. Excess fat is deleterious to health. It also depends on where the fat is as to what is the effect. Now, when you look at ectopic fat, what is it? It's triglyceride basically deposited in tissues other than what we've just discussed, or deposited in excess in these tissues where it has negative metabolic consequences. So, in the visceral organs and in the skeletal muscle, it can invade the organs and tissues and disrupt normal function, and it's associated with metabolic dysfunction, inflammation, oxidation, insulin resistance, and the consequences of dyslipidemia. Why do we get this? The mechanisms aren't very clear, but there is positive energy balance that can't be argued. You're taking in more than you're burning, to the point where you've exceeded your subcutaneous adipose tissue depot capacity. Now, this is quite a challenge because normally your subcutaneous adipocytes can increase 20-fold in diameter and 1,000-fold in volume before they become dysfunctional. So these subcutaneous adipocytes are initially insulin sensitive and participate in insulin signaling, but when they go beyond this and tip over into a dysfunctional adipocyte, this is when you lose your insulin sensitivity and the adipose tissue depot starts contributing to your insulin resistance and inflammation. So what are the sites where you can see this? Liver, muscle, visceral, including pancreatic, and pericardial fat. All of these contribute in various ways to our dysfunction. They all seem to have certain common pathways. Figure A is muscle, B is liver cell, and C is cardiocyte. Look, there's no point taking photos of things like this because there isn't a legend. I'm explaining the figure, but looking at this, you're never going to figure out in your phones again what it's useful for. So please, just listen to me. I'm happy to give out the presentation as a PDF if you want, right? So there is a common pathway. Free fatty acids go into the cell. Is this working? No, it's not. Okay. So look at the top, that side of each figure, free fatty acids go into the cell through this membrane-bound receptor called CD36 or fatty acid transport receptors, transport proteins. So one of two receptors. Now remember, Dr. Krishna Sheshadri again mentioned this. He talked about the FOXO pathway. He talked about the overlap of glucose and fatty acid metabolism and the toxicity that certain molecules can provide in the cell. So in the skeletal muscle, for example, if you have an excess of fatty acid, these go into long chain CoAs and then into DAG, diacylglycerol, and then into molecules that start inhibiting your glucose secretion and glucose sensitivity. In the liver cell, these again go through the FOXO pathway, again also mentioned by Dr. Krishna a little while ago, and inhibit glucose utilization in the cell and increase gluconeogenesis. In the cardiac myocyte, again the ceramides and diacylglycerols disrupt mitochondrial dysfunction, as they do also in the liver cell and in the pancreas. And the heart and the pancreas are the two most mitochondria intensive organs. And this mitochondrial dysfunction leads to mitochondrial cell death and heart failure through a variety of pathways. So a variety of pathways, but essentially starting with the toxicity of the fatty acid to these tissues by being converted into either diacylglycerols or phosphokinase pathways, or through the FOXO pathway, or through ceramides. Now, what are the implications? As I said, at some point they tip over from insulin sensitivity into insulin resistance. They're associated with dyslipidemia. There is inflammation because fatty tissue is a metabolically active organ that secretes a variety of inflammatory cytokines. In the liver, it can give you fatty liver disease and the subsequent consequences thereof. Pancreatic dysfunction, when the fat invades pancreas, you get beta cell dysfunction and alpha cell dysfunction eventually, and cardiovascular risk. Having said this, do we really have any easy way of figuring out what and where and when? Not really. You get a really blunt tool, waist circumference, which is a measure of your adipose tissue in your liver, in your visceral fat, and some amount of subcutaneous fat in the abdomen. But this is the most readily available. Waist circumference and waist hip ratio is the most readily available measure to us. An ultrasound can give you a measure of subcutaneous fat, not very good at figuring out visceral or especially intra-organ fat. It can give you some idea of muscle and liver fat, but again it can't quantify really well, and we know that ultrasound appearances of fat in the liver don't really correlate with either hepatitis or the amount of fat or even steatosis, right? Multidirectional CT does give you a much better idea, but then it is radiation exposure, and how frequently will you measure and how will you follow up linearly to see if there is any change in these depots. An MRI, yes, but expensive, research oriented, and requires a whole body MRI because you have to assess all the depots to then give you a good idea of which way you're going with what. So clinically speaking, a waist hip ratio and a waist circumference gives you a blunt tool, but an adequate tool to see if you're shifting these depots, if you're actually losing a little bit of visceral fat. So there are several factors. So we're getting to the summary bit. So there are several factors: genes, environment, and our behavior. But there needs to be some degree of calorie excess, which leads to fat accumulation, which then distributes to the various organs, which then goes into ectopic fat storage. Now, depending on where the ectopic fat is, in the heart, diastolic dysfunction; in the pancreas, alpha and beta cell dysfunction; in the muscles, impaired glucose uptake and muscle insulin resistance; and in the liver, we know increased hepatic glucose output, fatty liver, and an increase or a dysfunction in terms of VLDL and triglyceride output. And in the visceral fat, as a metabolically active tissue, increasing your free fatty acids and adipokines. So, are you sure you have the right presentation? I had a few more slides, never mind, okay. There was a couple of other slides which I had two versions of this. I think they've projected version 1 where I wanted version 2, but we can cover that. So on the whole, Triglyceride content in the liver and muscle usually correlates well with whole body and tissue specific insulin sensitivity. Ectopic lipids, though, are more a marker of an imbalance between the metabolic supply and demand at various states of insulin sensitivity, and an excess in ectopic lipids across the tissues gives you a variety of metabolic dysfunction, but effectively leading to diabetes, fatty liver disease, diastolic dysfunction, muscle insulin resistance, and at the liver level, of course, eventually fatty liver disease, steatosis, NASH, and cirrhosis. So I'm happy to stop here and take any questions.